Okay, can everyone hear me and see me okay? Sorry for the slight delay. Hmm. Okay, can someone just send a message on the chat on the screen that should be appearing, just saying that you can see me and hear me okay, if you can. I just want to make sure that everyone can hear me before I start. Okay, great, thank you. All right. If there are any problems, let me know. Any problems with the audio or the video? I'm not gonna have any slides up today because I was having a problem setting them up. But I'll do my best to kind of you know point you to appropriate slides whenever appropriate. I'm just gonna wait a couple more minutes until more people join the review session. To those of you that are just joining us now, I'm just waiting a couple more minutes until more people join the review session in case someone is late. Um, so just a reminder, I guess, I'm sure most of you know, but the final exam is on Tuesday, April 30th at 2 p.m. I think it's in Field House. So it's, I believe, around 100 multiple choice questions cumulative. So covering all of the material in the semester. Um, and yeah, so I think I'll get started. So what I'm going to be doing tonight is, if you go to the discussions board, um, the very first post was by Rebecca, and she posted quite a few questions, which I thought were great because Rebecca's questions kind of cover the entire course material. There are questions about, content from throughout the course, which I thought was really good. And so I'm going to be covering all of Rebecca's questions today. Julia is going to be covering all of the other questions that were posted in the discussions board, just because there were some questions that some posts that only had one or two questions, or the questions were a little shorter. So she's going to try to cover them tomorrow. Um, so yeah, I'm going to be doing Rebecca's questions for throughout the hour. They, like I said, they cover a lot of the course, so hopefully there will be some relevant and pertinent material to those of you who are watching. If there's time in the end, I'm going to open it up to questions through the chat. But let's see if there will be time. I remember I did the midterm one review session. There wasn't really a lot of time for questions throughout. So for now, if you could just use the chat, if there are any questions for clarification for what I'm talking about at that moment. So don't ask unrelated questions for now. Don't ask questions, for example, if I'm talking about, the criteria for anhedonia, for persistent depressive disorder. Don't ask me like, oh, what's the difference between alcohol abuse or dependence. Ask me if I said something about what I'm talking about and it's not clear. Then go ahead and use the chat to say that. And like I said, any technical difficulties, if you stop hearing me or you stop seeing me, please feel free to use the chat to let me know. So again, I'm going to be covering Rebecca's questions on the discussion board, starting from the top. And I'll talk about, a lot of the questions refer to specific slides. So I would recommend you all to have on a separate screen, have the slides, the lecture slides up on the side, because it will be useful to have a look at them as I'm explaining things that relate to these slides. Okay, so the first question was, can you explain the atheoretical approach and give an example? So I believe Rebecca was talking about the textbook talks a little bit about how the DSM-5 has an atheoretical approach, not just DSM-5, but starting from DSM-3. And so the background to this is that, as the textbook explains, and this is in one of the earlier chapters about theories, I believe. So the DSM-1 and 2 were both heavily influenced by psychoanalytic theory. So that's kind of, derivative of Freud's ideas. And that was kind of when the DSM-1 and 2 came out, I believe around the 60s. That was kind of the dominant theory or framework to understand mental illnesses and disorders. And that's why the DSM-1 and 2 used that framework and that theory. So one of the examples the textbook talks about is that in the DSM-2's definition of neuroses, which isn't even a disorder in the DSM right now, but it used to be a disorder that you can meet criteria for. The DSM-2 defined neurosis as being able to be controlled unconsciously and automatically by conversion, displacement, and various other psychological mechanisms. So this idea of unconscious control, conversion, displacement, is very Freudian ideas. It's a very heavy emphasis on the unconscious, which is a key thing you see in psychoanalytic theory. And the problem with that is that, and really why psychoanalytic theory fell out of favor as the years went by, was because it's not reliable. So you can't really measure whether someone is having unconscious, neuroses or any unconscious symptoms. You can't really see it, you can't measure it, and because of that, it's unreliable. For example, one clinician could diagnose someone with neurosis and the other may completely disagree with that because they don't really have a reliable way to measure these unconscious processes. And so this is part of why the DSM-3 moved to an atheoretical approach. And what this looks like in the DSM-3 and after DSM-3, DSM-4 and 5 included, is that it's more pragmatic and it's focused more on precise behavioral symptoms. So unlike the DSM-2's definition of neurosis saying, it may be controlled unconsciously and automatically by conversion, displacement, the DSM, starting from the DSM-3, really focuses on observable behavioral symptoms that are more precise. So for example, if you look at the DSM-5's definition of a panic attack, it says, a panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes and during which time 4 or more of the following symptoms occur. And they have very precise, a list of precise behavioral systems that occur in a panic attack. And this is kind of like an example in an atheoretical approach because it's not heavily guided by any major theory on panic disorder or panic attacks. And it's more pragmatic and it focuses specifically on behavioral symptoms that are observable and therefore are more reliable. Therefore, when you have observable symptoms, unlike the previous versions of the DSM, which were influenced by psychoanalytic theory, and you could have the clinicians disagreeing about diagnoses. Now, because they're observable, it's more reliable. Clinicians are more likely to agree to a diagnosis. And that's just one of the many reasons that the DSM moved to an atheoretical approach. But the key idea is that it's not really tied to any theory, like the DSM 1 and 2 were influenced by psychoanalytic theory, but it's more broad and pragmatic. So if there are no questions about that, always, again, feel free to send a message in the chat if there's any questions about what I'm saying, but I'm going to move to the next question. Again, I'm going through Rebecca's questions on the discussion board if you want to follow along. So I just explained the first one about the atheoretical approach. The next one is about slides 39 and 40 of stress and psychopathology lecture. So her question was, can you explain slides 39 and 40 of the stress and psychopathology lecture about the stress in the wild study? So that was from Aislyn's guest lecture about stress and psychopathology. So like I said before, I recommend those who are watching to just pull up the slides for that lecture to follow along, because I'm going to be referring to those slides and it might be confusing if you don't have the slides up. So to those of you who are listening, I recommend you to open the stress and psychopathology lecture, go to slides 39 and 40, where it says measurement of stress in the wild. That's what I'm going to be talking about. And while you pull those up, for those of you who joined us a little bit late, just to explain, I'm not using the slides tonight because I had some technical problems. I couldn't figure them to work as well as they did when I did a previous review session. So I'm just using the webcam and my voice, but I'm going to be referring to the lecture slides at some points. So I recommend you to follow along with those. And okay, so let's get back to the question. Stress and psychopathology lecture, the stress in the wild study. So basically they used the late positive potential, the LPP, as a measure of neuroresponse to reward. All you need to know is that it's an event-related potential, that you can measure it using EEG, and it's an index of sustained attention to motivationally salient content. And so they measured this LPP as well as the symptoms of depression in time 1, which was the start of the school year. So they did this with university students. At the start of the school year, they collected LPP and symptoms, depressive symptoms from first-year university students. And then at time 2, 6 weeks later, so midterm period, they collected depressive symptoms. And the idea of that was to see, that's what stress in the wild is. The idea is that the midterm period would be a period of very intense stress for students, which as students, we all know it's quite stressful to be going through midterms. And they wanted to exactly see that. It's, instead of having a lab measure, a lab task of stress where you kind of have, kind of like those that Dr. Weinberg explained in the lectures with the doors. Instead of having a lab task, they had a stressor that was in the wild, so a midterm period. So the results, if you see on slide 40, the one that has the scatter plot and the two scalp diagrams on the side. So looking at the scalp diagrams, remember that the one that has, if you see red in the top, the red indicates more reward sensitivity and a bigger difference between reward and neutral ERPs. So when you see the red on the scalp, that kind of is indicating a healthy reward sensitivity. So what you see, first of all, in the scalp diagrams on the right side of slide 40 is that subjects with low symptoms of depression, they had more reward sensitivity as indicated by the greater amount of red on their scalp. And those with high symptoms of depression at time two, as seen in the top scalp diagram, they didn't have as much reward sensitivity. So you can see, it's more yellow, doesn't have that bright red spot. So that's indicating a blunted reward sensitivity. And the scatter plot, obviously you don't have to remember any specific numbers in the scatter plot. All you need to know is that those who had a smaller or less positive late positive potential, so indicating again blunted reward sensitivity, were more likely to have greater depression symptoms 6 weeks into the school term, so during the midterm period. So what you see is that those who had greater reward sensitivity in a period of great stress were experiencing more depression symptoms. So again, one of the strengths of the study is that we're talking about real world stress. It wasn't just something that, they didn't just do a lab task. We're talking about midterm periods, so something that happens with students in their real lives and is, very, very important to students in their real lives. And in this population, and looking at stress in the wild, we saw that there was a relationship between greater depressive symptoms and less reward responsivity. So I hope that makes it clear for Rebecca's second question on this lecture and this study in particular. If there's any questions, let me know. Otherwise, I'm going to be moving on to the third question posted in the discussion board, which is about how does, as worded by Rebecca, how does axis 3 and 4 relate to axis 1 and 2? I don't understand how you would use all of the axes to make a diagnosis. So the axial system, just to clarify and to remind everybody, I think this is what Rebecca is talking about. Again, if it's something else, let me know. But in the DSM 3 and 4, there was a multi-axial system to classify mental disorders. And so how that looked was that it was almost like a hierarchical system where you have axis 1 being clinical disorders. So just kind of like the standard DSM disorders we know of, bipolar, panic disorder, PTSD, anxiety disorders, other anxiety disorders, depressive disorders, substance use disorders. Those would all go in axis 1. The exception would be personality disorders and intellectual disability. Those would be going on axis 2 of the multi-axial system. And so the idea is that personality disorders and intellectual disability are more chronic and life-enduring, whereas clinical disorders, for example, obviously not all of them, but things like depression, someone may have recurring depression or not. It may not necessarily be chronic, but a personality disorder is very hard to treat, very chronic. And you would also assume that personality disorders could impact treatment. And so this was another key idea behind the multi-axial system, was to look at things that may impact treatment. So again, axis 1, clinical disorders, axis 2, personality disorders and intellectual disability. On axis 3, you would have medical and physical conditions. So things like chronic migraines, severe insomnia, things like asthma, obesity, other medical and physical conditions would fall on axis 3. Axis 4 would have contributing environment or psychosocial factors. So for example, if someone's having family issues or just other psychosocial stressors, maybe living in an abusive household, things like that. And on axis 5, the last axis, it's just a global assessment of functioning. And so that would be a number from 0 to 100 that indicated how just a quantitative measure of how someone's general functioning is. So I'm not going to go into too much detail on that, but just remember that it's a global assessment of functioning. Again, The multi-axial system was abandoned in DSM-5. The DSM-5 does not use the multi-axial system anymore. How you would use all of the axes to make a diagnosis would be obviously depending on the patient, but an example of this would be, for example, you have a patient coming in. On axis 1, you would put a diagnosis of, let's say the patient that comes in has panic disorder and PTSD. So you would diagnose them, with panic disorder, PTSD, and those would both be in axis 1. Axis 2, let's say they have borderline personality disorder. You'll put that on axis 2. So now you have, panic disorder and PTSD on axis 1, borderline personality disorder on axis 2. Axis 3, let's say they have insomnia. That would be a medical condition, so that would go on axis 3. Axis 4, again, let's say they had an abusive household. So maybe they were a teenager and they were living in an abusive household with abusive parents. Axis 4, global assessment of functioning. Again, not going to go into too many details, but let's say that you ran an assessment of functioning with them and saw that out of 100, their functioning was about a 60. So, maybe their functioning was far from ideal, just their general functioning, daily functioning in daily life. So Rebecca's question, going back to the question, she says, I don't understand how you would use all of the axes to make a diagnosis. You wouldn't make a diagnosis based on all of the axes. You would do a diagnosis for the clinical disorders, right? So for example, you would diagnose panic disorder. That would go under axis 1. And then panic disorder will have its own criteria, right? But the axial system was just used to make a diagnostic impression. So you would make a diagnosis on, let's say, panic disorder. You would use the symptoms, make the diagnosis, and put that diagnosis kind of in axis 1. And then you would look at other factors. So beyond just the diagnosis of panic disorder, does the person have a personality disorder? Does the person have any medical or physical conditions? For example, insomnia could make treatment more difficult. If they have stressors, axis 4, if they have, psychosocial factors, family abuse or other stressors, that could also impact treatment. But you wouldn't make a diagnosis based on the other axis. You wouldn't look at medical conditions, for example, and use that to inform your diagnosis of panic disorder. It was just a system that was used to kind of make a big picture of how that person's life is at the moment. So including the clinical disorders like panic disorder, also other factors. So that's the purpose kind of behind the axis. So one question, can some axes be empty? Yeah, they could be empty. So for example, axis 2, personality disorders and intellectual disability. If the person didn't have any personality disorders or intellectual disabilities, you would skip that altogether. So let's say you see someone who comes in. That's a great question, actually. Let's see, someone comes in and they have bulimia nervosa, and they also have migraines, but they don't have a personality disorder or intellectual disability. So in that case, axis 2, it would be empty. There wouldn't be anything in it. But then you would include, bulimia nervosa in axis 1 because it's a clinical disorder, and let's say the migraines in axis 3 because it's a medical condition. Yeah, so some of the axes could be empty. It really depends on the person. It's just used to make an impression of the person's functioning. So moving on to, if that's clear again, moving on to the next question, and that was, can you explain the results of Rupy and family study on slide 52 of lecture 6? So yeah, lecture 6, that was one of the depression lectures. So I'm just going to give a moment for everyone who's around to pull up the slides from that lecture. And go to slide 52 because I'm going to be talking about those two slides, 52 and 53, I think they are. The one that says Rupy in families and Rupy in at-risk siblings. And so again, just to remind everybody that I'm going through the discussion board questions, I'm going through Rebecca's questions. The other questions, Julia is going to go through tomorrow session. And if there's time tonight after I answer these questions, I might take some questions from the chat, but not sure if there's going to be time. Okay, so lecture 6, slide 52, Rupi in at-risk siblings and families. So basically, we talked about a lot about reward positivity, or Rupi. The idea is that, I even talked about it earlier in this review session, the idea is that individuals with depression, they show blunted responsivity to reward, as measured by EEGs and event-related potential seen in those EEGs. And so the point of the study of Rupi in families is that you wanted to know if the Rupi is familial. So if Rupi is evident in only people who have depression, or if it's present in those who have depression and also their siblings. Because if the Rupi is present only in people that have depression, then the Rupi indicates a sign or a sequel of depression. So it would be specific to depression, and maybe the Rupi would be indicating something about depression itself. But if you see it in siblings of people with depression, who may not necessarily have depression, then it would indicate that Rupi isn't specific to depression, but that rather it's a vulnerability marker. So that there's something familial, something genetic that causes a vulnerability, and that's why you're seeing Rupi even in siblings of people who have depression, even if those people don't have depression themselves. So that was the point of the study. Kind of remember a little bit, and I'm going to go through this as well, the PTSD study where we were talking about whether things are a sign or sequel, or if it's a vulnerability marker. That's kind of the point of the study with Rupi and families, is just investigate, what exactly is the Rupi? Is it part of depression, or is it a vulnerability marker to depression? And so if you see the slide that has the 2 scalp scans and the graph with the Rupi, the blue and the red Rupi curves, if you may call them that, you see that in siblings of probands with high positive affectivity, so in this case, that's kind of like what do you call it? A proxy for depression is low positive affectivity and high positive affectivity. So the idea is that, low positive affectivity is depression or akin to depression, and high positive affectivity would be, healthy individuals with no depression. And so you see in the red curve, do you see how it's going further down? Remember that these graphs, they're actually flipped. So positive is down. So they're going further down. That means that it's a higher difference. So that the red curve, you see greater reward sensitivity. And that red curve was characteristic of siblings of probands with high PA. So siblings of individuals that have high positive affectivity, so no depression. But in siblings of probands with low PA, so probands with depression, for example, or something akin to depression, again, not necessarily depression, but something akin to it, they would be the blue curve. So the idea behind this is that in siblings of individuals that have depression, you also see blunted reward responsivity. You also see blunted Rupi. And so this indicates that the Rupi isn't a sequel or a sign of depression, because if it was, you would only see it in the individuals that have depression and not in their siblings, because their siblings may not necessarily have depression. But the fact that siblings of individuals that have depression show the blunted rupee indicates that rupee is possibly, again, this research is very recent. This is one of Dr. Weinberg's articles from only a couple years ago, but indicates that rupee is probably a vulnerability factor, a vulnerability marker for depression. And so maybe, it's indicating maybe people who have blunted blunted responsivity to reward may be more likely to develop depression, and not necessarily the other way around. Not necessarily people who have depression end up developing a blunted responsivity to reward. So I know that these studies about rupee can be a little bit confusing. So again, let me know if you have any questions about that. But for now, I'm going to be moving on to the next question, which was whether the vigilance avoidance theory is specific to Tom Borkovec's theory of worry. And I think Rebecca, in her question, she says it was described in lecture 11, but I think it actually wasn't in lecture 11. It was in the GAD lecture. I forget which lecture number that was, but just the lecture where we talked about GAD. So I'm just going to see which slide number it was. So we're talking about 23, slides 23 and 24 in the GAD lecture. So, but this is going to be pretty quick. Tom Borkovec's idea is that the worry is kind of like a cognitive avoidance to low probability events. So for example, like Dr. Weinberg talked about in the lecture, you're worried about, your a loved one, let's say like your mother getting in an accident. So you're worried about that, and even though it's a low probability event, you keep worrying about it, and you keep thinking about it, and that's kind of a way to avoid, like even if it doesn't happen, it's a way to avoid to deal with the possibility of these events happening, these accidents happening. So if that's unclear, I just recommend you to watch the recording again on that lecture and that specific part, because that I think Dr. Weinberg made pretty clear. But again, back to the question: is the vigilance avoidance theory specific to Borkovec's theory of worry? Yeah, I don't know for sure, but I don't think that what Dr. Weinberg explained in the following slide about vigilance avoidance is, I don't know if it can be applied to other theories. She was using it really to explain Borkovec's theory of worry. And so the idea is that you stay vigilant for possible threat, but then you avoid it. And then you never know if that is actually was a threatening situation or event or stimuli or not. And so that, I think that wraps up that question. But again, I think that if some of you may not remember exactly the Tom Borkovec's theory of worry, so I recommend you to just watch the recording again. And if you have any more specific questions, let me know. Next question was, what's the difference between panic and anxiety? And so it really depends on panic and anxiety. They're very broad terms. It really depends on the context that someone is talking about them. But generally, when we say anxiety, we are usually talking about any kind of anxiety disorder. So including panic disorder, GAD, phobias, and of course, previously OCD and PTSD. Panic, you would normally be talking about either panic disorder or panic attack in particular. And so panic, again, the DSM makes a distinction. It's in your textbook as well. A panic attack, abrupt surge of intensive fear or intense discomfort, reaching a peak within minutes, and during which time 4 or more symptoms occur. Panic disorder is a diagnosis that consists of recurrent unexpected panic attacks with persistent worry about these panic attacks or change in behavior due to them. So generally when we talk about panic and anxiety just broadly an anxiety disorder, panic, you could be talking about panic disorder or panic attack. It really depends on the context. They're two very broad terms. And of course, in the real world, you see people talking about panic and anxiety in situations where they're not talking specifically about anxiety disorder. Because all anxiety is not necessarily an anxiety disorder. So anxiety, to some extent, is normative. But yeah, again, it really depends on the context that someone's using these terms. Next question is, what would be an example of a blunted response and reactivity following trauma? It's a little bit of a broad question. I'm not sure exactly what you're talking about. But if you think of trauma, you can think of trauma as being stress. Trauma and stress are pretty similar. So if you think of trauma as stress, the study I was talking about from the stress and psychopathology lecture about the stress in a wild study with the students in the midterm period, you can think about it that way: blunted responsive reactivity following the stressor. Following midterm events, in midterm events, you see blunted responsive reactivity, and that's related to high symptoms of depression. So that would be an example of blunted responsive reactivity following trauma. Okay, let me just get the next question. So next question was about the PTSD OCD lecture, and specifically the study about combat exposed and unexposed twins or co-twins with or without PTSD and brain abnormalities, in particular hippocampal volume. And so the question was, so again, I'll recommend you all to go to get the PTSD and OCD lecture slides and go to slide 22. I'm going to be talking about those slides. It says, does the results point to the abnormalities being a scar or a sequel of PTSD? So in the lecture, to those of you who were in the lecture or saw the lecture, hopefully most of you, if not all, remember that Dr. Weinberg was using these slides with the bars, with the bar graphs, and the EXP plus, EXP minus, UXP plus, UXP minus. These are not the results of the study particularly. They were just used by Dr. Weinberg as a thought experiment of, okay, if the study's results were like this, what would it point out? So just remember that, slide 22 in particular, it's not from the study's results. It was just used by Dr. Weinberg in the lecture to kind of guide you through thinking about what pattern of results would suggest each of the explanations, whether then they're scar or sequel or something else. But slide 22 in particular, and this is the one that has on the left, it says key, and then EXP plus, EXP minus, UXP minus, UXP plus, UXP minus, and it has a bar graph on the right side. So in this slide, you see EXP plus, they have a bigger bar, so that's just kind of indicating bigger brain abnormalities. So EXP plus are the twins who have PTSD and were exposed to combat. So because in this slide, in these results, if these were the study's results, because we only see the brain abnormalities in those who have PTSD and were exposed to combat, that supports the theory that would, because again, not the study's results, but that would support the theory that brain abnormalities are a sign or a sequel of PTSD. So yes, to answer Rebecca's question, that's what the graph's results point to. And the reason why is because if you only see the brain abnormalities in those who are exposed people and have PTSD, if you only see it in that group, then you're probably looking at something specific to PTSD. So that would support it being a sign or a sequel of PTSD. But if you go to slide 23 and you see that's the slide that has two bar graphs. And so one on the left side, you see higher bars for EXP plus and EXP minus. And the other one is EXP plus and UXP minus that have the EXP plus, sorry, that have the higher bars. So on the left side bar graph, because you see it in both EXP plus and EXP minus, so you're seeing this in both those who were exposed to combat or exposed to trauma and have PTSD, and in those who were exposed to trauma but don't have PTSD. So when you see, if we saw brain abnormalities in both these groups, exposed with PTSD, exposed without PTSD, you would have you would see that would be indication of a constant exposure to trauma. So exposure to trauma would exposure to trauma would sorry, I lost my train of thought. So left bar graph, going back to it in slide 23 of the PTSD lecture, if you saw brain abnormalities in those exposed, both exposed to trauma and with PTSD, and exposed to trauma without PTSD, that would suggest that brain abnormalities are specific to a specific consequence to exposure to trauma, and not PTSD in particular, because you always see it in you also see it in individuals who do not have PTSD. And in the right hand side, another bar graph, if we saw that you saw brain abnormalities in both EXP plus and UXP plus, so both those exposed to combat and with PTSD, and those unexposed to combat and with well, not with PTSD, but their co-twin has PTSD, because the UX are the co-twins. So if you saw this in those exposed to combat with PTSD and their co-twins, which is the UXP plus group, that would suggest a familial vulnerability to PTSD, because you're seeing it in both the sibling with PTSD and their co-twin who does not have PTSD. And because you're seeing that, that's not specific to PTSD and not specific to exposure, because the co-twin was not exposed to combat or to trauma. So again, to recap, to sum it up, slide 22 are what the results would look like if the brain abnormalities were a sign or a sequel of PTSD. Slide 23, on the left side, that's what the results would look like if it was if brain abnormalities were a consequence of exposure to trauma, and specific to exposure, not necessarily PTSD. And on the right side is what the results would look like if we saw a familial vulnerability. If brain abnormalities were a familial vulnerability, because you'd be seeing it in both those who have PTSD and their co-twins who do not necessarily have PTSD. And the actual results of the study, which are described, later on in the following slides, with the tables that have all the numbers and explained by Dr. Weinberg in the lecture. The actual study results resemble more the bar graph on the right hand side of slide 23. So if we, again, that bar graph in specific isn't the results of the study, but if we did a bar graph with the results of the study, it would look kind of like the bar graph on the right hand side on slide 23. So this is a complicated study. It takes a while to understand it. It takes a while to understand kind of what results fit each possible explanation, but just remember, remember the groups. So if you see it only in a group that has PTSD and was exposed to combat, then suggests that that's specific to PTSD. But if you see it in other groups, not specific to PTSD. So again, let me know if that's clear. If it's unclear, I can always explain it again. But otherwise, I'm going to move on to the next question, which is on slide 44 of the PTSD OCD lecture. So same lecture. It says that people with OCD have short-term memory issues, but a study in the textbook seems to contradict this. Could you explain the Concordia University study by Adam Radomski? So yes, so Rebecca's completely right in this. It's so Dr. Weinberg was talking about possible explanations behind OCD, and one of them is that maybe people with OCD have poor short-term memory, and that's just a possible model of OCD. So that's just an idea of something that may cause OCD, or specific short-term memory deficits could cause OCD. However, yeah, like pointed out in this question, there is work suggesting that this model may not necessarily be accurate. So it's important to remember, because psychopathology is such a new field and is still emerging, and the research, every year there's new research that kind of changes the ways we think about certain mental disorders. So a cognitive model of a disorder like this one, OCD being caused by short-term memory deficits, may not necessarily be supported by all the research. And so what the textbook talks about is a study by Adam Radomski. I'm just going to explain it quickly. So participants with OCD and control participants who were undergraduate students without OCD, they were told to basically turn on, then off, and then check a stove in a ritualized manner. So kind of like resembling the ways that someone with OCD would check a stove, kind of simulating what a compulsion from someone with OCD. And then the participants were told to identify which. So basically, in the manner that they were told to turn on and then off, and then check the stove, they were told to turn on this knob and then turn off that knob, that switch or whatever. They were later asked to identify which knobs they had checked previously, which 3 out of 6 knobs, and then rate the confidence, vividness, and the detail of their memories. So you're making people with OCD and the control group, which were students without OCD, you're making both of them do the checks that would resemble compulsions in OCD, and then you're checking their short-term memory. So that was what Radomski was doing in his study. And so what he found is that both groups of participants, so both with OCD and the control group, reported reduced memory confidence, vividness, and detail following repeated checking. So participants with OCD reported reduced confidence in their memory. That goes along with the model, but contrary to what the model says, it's not specific to OCD. Even also the participants, the control participants, also reported reduced memory confidence following repeated checking. And so that kind of suggests that there's a self-perpetuating cycle where the checking increases doubt. So if you do the checking, if you keep checking if your stove is off, that actually increases the doubt, which is kind of counterproductive because you're checking to make sure, but that may actually increase your level of doubt and lead to more checking. And so actually, when you think about it that way, even though it's not specific to OCD, it could be that these short-term memory deficits are related to OCD, because people may start doing the compulsions for other reasons, not necessarily deficits in short-term memory, but once they start checking, that compulsion becomes a perpetuating cycle where they will check, and then that will lead to reduced confidence in their short-term memory, and then that will lead to more checking, and then that will just, it will just be a self-perpetuating cycle. But yeah, it seems like it might not be specific to individuals with PTSD, but it does seem to individuals with OCD, not PTSD. But it does seem that there's something about this tracking that influences short-term memory. So moving on to the next question. In the DSM-5, is there a difference between abuse versus dependence for substance use disorder? It says that abuse and disorder and are considered as one. What would they look like if they were separate? So basically, just to clarify, I would suggest you to have a look at the lecture on alcohol use disorder. Basically, in the DSM-4, what a lot of these terms are thrown around, like substance abuse, substance dependence, substance addiction, which isn't referred to in the DSM. But the DSM-4 had substance abuse and substance dependence. So the DSM-4 distinguished between substance abuse and dependence. They were both a maladaptive pattern of substance use leading to distress or impairment. Abuse was more kind of like behavioral. So things that, for example, failing to fulfill role obligations, putting themselves in physically hazardous situations, getting into legal problems. So things like a DUI, indicating potentially alcohol use disorder, or in this case, alcohol abuse, because we're talking DSM-4, and social problems. So again, maybe a breakup caused by alcohol abuse or another drug abuse. And dependence was thought to be more of like a kind of like a psychological thing. So dependence included tolerance, withdrawal, taking a substance more than intended, in values more than intended, failing to cut down use of a substance, etc., etc. And so, again, the DSM-4 distinguishes between substance abuse and dependence. The DSM-5 does not anymore. DSM-5 doesn't distinguish between substance abuse and substance dependence. It only has some substance use disorder, and it has alcohol use disorder, cannabis use disorder, cocaine use disorder. So for different substances, but it's only one. There isn't this distinction between abuse and dependence. So again, this is explained by Dr. Weinberg in the alcohol use disorder lecture. But all you need to remember is that DSM-5, there was this split between abuse and dependence, where abuse is more behavioral, so like getting into legal problems, social problems, putting themselves in physically dangerous situations. Independence was more of a psychological syndrome. So, dependence had as symptoms for dependence, it included tolerance, withdrawal, taking a substance more than intended, giving up harder activities. And yeah, so DSM-5 got rid of the distinction between abuse and dependence and now only includes substance use disorder. And also, the DSM-5 curiously also has criteria for substance intoxication and substance withdrawal. So it actually, withdrawal is one of the symptoms of alcohol use disorder, but the DSM-5 also includes what withdrawal looks like for alcohol, because withdrawal from alcohol is different from withdrawal from cocaine or withdrawal from methamphetamines. But yeah, it doesn't make the distinction between abuse and dependence, not in the DSM-5. It's just substance use disorders. So to get to the last question by Rebecca in the discussion board, just reminding everyone the other questions are going to be answered by Julia tomorrow. The last question was, those with antisocial personality disorder did not have this stress over the symptoms, just to clarify. And this is something that they share with psychopaths. So, yes. So, this is what we call ego syntonic. So, the idea is that, those with, say, depression, that's an ego dystonic um, disorder, because those with depression don't want to be depressed. They don't see it as something that's part of them. Well, they might see it as something that's part of them. It's not necessarily that, but they experience significant distress about being depressed. So that's what ego syntonic is. Those with antisocial personality disorder don't have any distress over the symptoms. And actually, many other personality disorders are like this, but antisocial personality disorder in particular, yeah, you don't see distress over symptoms of antisocial personality disorder. And you also see this in psychopaths. Psychopaths also don't have any distress over, not symptoms, it would be more characteristics, because psychopaths isn't a diagnosis of the DSM, so you wouldn't call it symptoms. But yeah, it's also an egocentric syndrome, or concept, in that they're not really distressed about psychopathy or their antisocial behavior. And Yeah, so that's it. So I covered all of Rebecca's questions, which is what I wanted to do tonight. So if there are any more questions, we have, I started a little late, so let's go until 9:05. I'm just going to answer any questions that you might have in the chat. So any other questions about what I covered tonight, or anything else in the course, please, you can go ahead and post post it in the chat, and I'll get to them. If there are no more questions, then I'll be ending the review session in a short bit. And so, just a reminder, tomorrow afternoon from 3 to 4 p.m., Julie is going to host another review session. So she's going to be answering questions on the discussion board. And maybe if she has time, she could go over chat questions, but she's doing, I think, a little more questions than me. So there might not be time for questions in the chat. So just going to give a couple moments, just in case anyone who's watching has any questions. You can post it in the chat. Otherwise, we're always, reachable via email. You could always post on the discussion board as well. Julie and I could see if we can answer the discussion board questions that we haven't been able to cover. In our video review sessions. Okay, so I was wondering if slides not covered in class will be in the finals. So for example, schizophrenia after slide 66. So yeah, slides that Dr. Weinberg did not cover in the lecture, those will not be in the final. But remember that textbook content, that is, that's all fair game. And so if the slides may talk about content that is also covered in the textbook, and if it does, then that might be in the final, because all textbook content, of course, from the chapters that are assigned, are fair game, and all questions about articles are also fair game. But yeah, about a slide in particular, if we're not cover it in class, if she skipped it or didn't have time to go over it, that's not going to be in the final. So just gonna wait 1 or 2 more minutes to see if any more questions pop up. So again, reminder, final is on Tuesday, April 30th at 2 p.m. I think it's in the Field House. I will double check because I'm not sure. Let's see. questions about etiology of genre of ASPD. Can you be more precise? I'm not sure exactly what you mean. XD. The study by Bloningen. So was that one of the? Let me have a look. That wasn't familial aggregation, but where was this mentioned in one of the lectures? Let me just pull up the antisocial personality disorder lecture. Yeah, March 13th. Okay, I'm just gonna get the lecture. Just a moment. I'm just trying to find. Oh, okay, I see. Okay, I found the slide. So in the ASPD lecture, there is a question. There's a slide talking about how data from twin studies suggest genetic contributions. Estimates of strength of genetic contributions varies. Oh, okay, I see. So basically, what that's talking about is that, like many other mental illnesses, we see familial aggregation. So antisocial personality disorder seems to be genetic. You do see that, if a parent has antisocial personality disorder, their offspring is more likely to have antisocial personality disorder as well. So that's what a couple first points are talking about. The genetic pathways, which I think your question may be about, basically is talking about how, as with many other things, if there are many ways that genes can exert influence. So for example, genes could lead to a difficult temperament and impulsivity, and tendency to seek rewards, etc. And these types of behavior may be part of antisocial personality disorder, and so that would be kind of like genes directly leading to antisocial personality disorder. But also, genes could, instead of directly making someone experience symptoms of antisocial personality disorder, they could make someone vulnerable to familial stressors. So, for example, the genetic vulnerability that's being passed from parents to offspring could be that it could be, for example, that a temperament trait that makes let me see how I can explain this, that makes the child more likely to be exposed to stressors. So, for example, some children, if they are very fussy, right, when they're growing up, parents may be more harsh on them, and the harsh parenting may be what's contributing to antisocial personality disorder, not in specific. So do you understand what I mean? So basically, the genetic contribution may be directly affecting traits that relate to antisocial personality disorder, but also genetic contributions may be affecting, maybe making someone more likely to be exposed to stressors that later lead to antisocial personality disorder, for example. And that's number 3 out of the 3 genetic pathways in the slide, with the 2 twins, the slide that says etiology genes. And moderating susceptibility to environmental risk factors, that's kind of what we see from the MAOA study, where the Caspi et al. MAOA study, where children with low MAOA activity and high MAOA activity, that in particular, so that's kind of like a genetic contribution, that didn't really make a difference in antisocial personality disorder diagnoses, but low MAOA activity, when combined with childhood maltreatment, or with severe childhood maltreatment, that led to very high indices of antisocial behavior, whereas high MAO activity led to, wasn't necessarily related to it. And so that would be an example of genes moderating susceptibility to environmental risk factors. So I hope that was clear. If it wasn't very clear, please feel free to email us and we'll explain it more in depth. I would suggest you again, and just in general, yeah, you're welcome. You're welcome. I hope, I'm sorry. I know it was a little wordy, but I hope that it was a little clear. But yeah, make sure to please email us if you have any more questions about that. And with that, I want to wrap this up and wish everyone a good night. Wish everyone good luck for the final on Tuesday afternoon. And yeah, exams are all almost over, so just keep pushing through, and it's going to be over soon. So best of luck with everyone studying, and good luck in the exam as well. And thank you for following the review session with me today, and the next one with Julia will be tomorrow afternoon. So okay, good night, everybody.